Morning, everyone. My abstract topic is the Dutch lung cancer audit. It was a real-world data on elderly stage 3 non-small cell lung cancer, small cell lung carcinoma treated with radiation. Next, please. Next slide. Next. Okay. First of all, what is a clinical auditing? It is a systematic critical analysis of quality of medical care, including the procedures used for diagnosis and treatment, and the resulting outcome for the patient. In simple words, it assesses if a certain aspect of healthcare is being attained by the patient according to standard clinical criteria, which are generally set by a clinical auditing board. It is generally practiced in the European countries, which is UK and the Netherlands. The process, the steps which are included in the clinical audit, they include first of all, in step one, we have to identify the audit topic. Then we have to set the standard criteria, and we have to match those standard criteria with the predetermined criteria of the study which have already been done. Then, according to those criteria, data is collected and data is analyzed. In that analysis, we generally match if the standard criteria which were present, which were there, are according if they are being followed and if they are being matched or not clinically as well as theoretically. And then, if they are not, then changes are implemented for welfare of the patient. Next, please. Okay, this was now in this lung cancer audit, mainly non-small cell lung cancer and small cell lung cancer patients of stage 1 to 3C, according to AJCC dates, they were included. Mainly the radiation techniques which were the protocols which were followed were in majority of patients SPRT was followed, and followed by concurrent CPRT. Concurrent CPRT, it was preferred over sequential CRT, mainly I suppose the trial by McGuire et al., in which the concurrent CPRT which benefited over sequential CPRT in terms of overall survival as well as the tolerance of the treatment. The exclusion criteria, it was the stage 4 lung cancer and palliative and patients with poor ECOG performance status. Next slide, please. Now, the feedback to the hospital, it was given in form of stage 4-5 toxicity. These were early toxicities which were evaluated less than 90 days after treatment in the year 2015 to 17. And as we can see, it was higher. Generally, in early days, it was higher in SPRT arm as compared to the concurrent CPRT and conventional RT arm. Next, please. In the study aim in this was to analyze definitive chemoradiation in elderly patients which were marked as above 75 years of age with stage 3 non-small cell lung carcinoma. Next slide. The study methodology was that they analyzed the percentage of stage 3 non-small cell lung carcinoma which were treated throughout 2015 to 2018 in a period of 3 years with either sequential chemoradiation or concurrent chemoradiation. The concurrent CTRT is scored in case if RT is started within 30 days of prior chemotherapy, then it can be considered as concurrent CTRT. Information was collected on patient characteristics, tumor size, and treatment characteristics. Toxicity as well as mortality was scored within 3 months after the end of RT. Okay, in this the results of this study, there were two arms: the non-elderly less than 75 years and the elderly more than 75 years. The mean age for in the non-elderly was 63.6 years and in elderly was 78.9 years. The predominance of males in both the arms, and WHO grade 0. There were mainly the patients of primary tumor, which were 2527 in the non-elderly and 428 in the elderly arm, as compared to the recurrent tumors, which were 88 in non-elderly and 15 in the elderly arm. The pathologically, all of those were the pathologically proven, histopathologically proven cases cases of non-small cell lung carcinoma of either stage, clinically stage 3A, 3B, or 3C. This is according to the AJCC, in which the stage 3C was added later. And the type of chemoradiation which was followed were in 1738 patients in the non-elderly were concurrent, and in the elderly 196, and sequential patients in the non-elderly group were 512, and in the elderly they were 146. The number of patients that were missing or lost to follow-up or lost or didn't complete treatment, they were 371 in the non-elderly and 102 in the elderly. And if the cumulative dose which were reached as planned by the treating physician, it was in 271, it was reached in the non-elderly and in 374 in the elderly now. Next slide, please. The overall toxicity which was recorded were more, as you can see, in the non-elderly as compared to the elderly. The toxicity which were less than grade 3 and more than grade 3, they were also more. And as we can see in the concurrent setting, the toxicity was way more as compared to in the sequential setting. Uh, uh, in terms of less than grade 3, in more than grade 3 in sequential setting, the toxicity is more as in the non-elderly as compared to the elderly. The patients which were missing, they were 100.
1 more minute to go.
Next slide, please. The mortality, we can see it was the concurrent CTRTM. The mortality was 70 in cases of the non-elderly and 70 in cases of elderly. And within the it was within the 90 days. And after finishing CTRT, it was 14 cases of non-elderly and 15 in cases of elderly. There were some patients that were missing from the study or they were lost to follow. Next slide, please. The conclusions mainly of this study was that the concurrent CTRT, the tolerance of the concurrent CTRT is not worse in the elderly as compared to younger patients, and there was no difference in acute toxicity between elderly as well as the young patients. The 90 days mortality, which was 5.2% for the younger and 9% for the elderly patients. So concurrent CTRT, which is considered to be non-inferior in cases of elderly, the study proved that it